Okay, so let's talk a little bit about depth. So this is all, this picture here is coming from the TRUST study done by Tessero. So the surrogate markers with ultrasound, what are some of the ones you guys know when you're trying to determine if it's in the main stem or if it's in the right place at the carina? What other things can you use your ultrasound to look for in terms of lung?
Lung sliding.
Yeah, lung sliding. And what else?
Not the mark study?
Not a mark study. So it's one that we don't talk about a lot, the diaphragm movement. And so the problem with the surrogate markers for main stem intubation versus at the carina is that in small kids, even with a little bit of positive pressure, you can have movement on the opposite lung just because of how little they are. The air can move over. So you might be fooled into thinking, oh, I'm in the right place, but actually you're down the right main stem or down the left main stem. So in neonates, you can actually see the tip of the ultrasound of the trachea, tip of the ET tube with the ultrasound, but it doesn't work so well in bigger kids. We also know that these indirect surrogate markers are inferior to chest X-ray. So there are times as well that you cannot use those types of markers. So if you have a pneumothorax on one side, you're not going to see lung sliding no matter what on that side. If you have subcutaneous emphysema, pulmonary effusions, pulmonary malignancies, pleural scarring, or ET tube obstruction, you're not going to be able to use those surrogate markers. So Mark came up with this wonderful study, the TRUST study, so the tracheal rapid ultrasound saline test. And they basically look at the accuracy of tracheal ultrasonography of saline-inflated ET tube cuffs for confirming the correct depth of the ET tube. This was a prospective feasibility study in children 3 months to 18 years, which was done in the OR. And they used the ultrasound at the suprasternal notch, which was performed during transient endobronchial intubation, which was confirmed by the gold standard of fiber optic bronchoscopy, and the ET tube at a correct endotracheal position. So the cuff was inflated with saline up to a maximum of 35 millimeters of mercury and a maximum of 6 seconds, so what we would think is a safe level. So when the saline cuff was not visualized, this was when it was always in the right main stem bronchus, and it was always visualized when it was in the right position at the carina. Does that make sense? So if you see the saline-filled cuff at the sternal notch, you know you're in the right place. If you don't see it, in this study you were too low, but it's possible that you could be too high as well. So they had 42 patients. Their sensitivity was 98.8%, specificity of 96, PPV of 96, and an MPV of 98. And the mean duration of the ultrasound exam was 4 seconds. So you can know within 4 seconds of them coming in if the tube is in the right place or not in terms of depth. So in this picture on B, this is when you're in the right main stem bronchus and you cannot see the saline-inflated cuff. Versus in C, we're in the right place and you can see the saline-inflated cuff. And so the difference is when you have the saline there, if you think water, you can transmit beams through. So you're able to see posteriorly more than you can see when you just have your normal trachea. When you're actually inflating, you can also see the little microbubbles moving around the cuff as well. Any questions about that?
So ideally it's like a dynamic test, right?
It's a what test, sorry?
Like dynamic test, right? Like you flush, and when you're flushing, you do the skin, right?
Ideally, it's a dynamic test as well, yeah. Okay, so tips and tricks, some of the things that we've already talked about. So ensure to apply that light to moderate pressure. If you don't, you're going to have the esophagus behind the trachea and you're not going to be able to determine what you're looking for. Because really, again, you're looking for the like a double trachea sign so that the tube is in the wrong place in the esophagus versus knowing it's definitely in the trachea. Like I talked about, rocking the transducer or sliding the transducer to the left to be able to see the esophagus and the trachea always at the same time without applying pressure. And then using this dynamically for intubation and for your confirmation of the suprasternal notch with your TRUST study. Any questions for pneumothorax? No, let's move on. We're going to go into the chest now. So you guys are pretty aware of this, of where to go. So we are looking at different locations. The right upper quadrant, the left upper quadrant, these are for your hemothorax views. And then the midclavicular line, left and right, looking for your pneumothorax and for your contusions, pulmonary contusions. So in terms of where to go with a transducer, again, you're going to use your high frequency linear transducer for the lungs. You're going to go down the midclavicular line on both sides. Initially, we talked about doing 3 to 4 rib spaces to confirm pneumothorax, but if they're very small or they're loculated, you might miss them. And so I would recommend going down to the diaphragm on both sides. And that way you can also look for your beelines as well. So we talked about what type of transducer. So absolutely, as per our normal lung, you can use your high frequency linear transducer. But if you're in a high stakes situation, the child is unstable, you don't have time to change your transducer, you can by all means use your phased array or your curvilinear, which you're already going to be using for your FAST. So in terms of where to go, you guys know this, normally in the lungs we would do 6 zones. Because this patient is supine, you're not going to be sitting them up and moving them around. You do not do the back. You could consider doing the anterior axillary line or the mid axillary line, looking for beelines if you were concerned about a contusion. So you guys have seen this before. This is our normal lung. You can see the pleural line very well at the top, A line, so reverberation artifact down, and then your rib shadows. And full play, there we go. So this is what your ants marching at your pleural line, the pleural rubbing looks like, which is normal. So we're supposed to see that. Here is another picture of normal lung sliding, and this is the appropriate way that you should be doing your lung scans when you're looking for pneumothorax. So make sure your patient is supine, and again, in a trauma, they're likely going to be. And you want, in this video, you can see how they kind of stop and listen. So you see one rib space, they stop. You see lung sliding, you move to the next one. So here is M mode. And this is an example of our normal sandy beach or the seashore sign. So at the top, because you have the top half of our screen, because you have, this is the muscles and the intercostal region, you're going to see static straight lines. But in the lungs, because there's breathing and there's movement, it's a little more hazy, and that's your ocean. So in our second case, we have a 12-year-old male who's run over by a car. He's got tire marks on his chest. He's coming in with tachypnea and increased work of breathing. And here's what you see on your lung ultrasound. What do you guys see? Absence of lung sliding, absolutely. So he has a pneumothorax. So you can appreciate there's no ants marching, there's no shimmering at the pleural line, and there's no comet tails coming down. So in this case, he had needle decompression followed by a chest tube. His clinical status improved, and he was admitted to the ward. So ultrasound is more sensitive for pneumothorax versus a chest x-ray that is supine. So you're going to see this faster. Think of how long it's going to take you to get your chest x-ray in this type of patient. Whereas if you include this in your primary survey, you could know this within a couple of minutes of being in. So in terms of pneumothorax, if you have no comet tails, it's 100% sensitive, but 60% specific for pneumothorax. If you have absent lung sliding, 95 to 98% sensitive, but not very specific. If they're both absent, it's 100% sensitive and 96.5% specific. The presence of sliding has a negative predictive value of 90% for no pneumothorax. If you have sliding and comet tails, it's 100% negative predictive value for no pneumothorax. You can also do what we were talking about earlier, the color Doppler at the pleural line. And if you see color movement when you're very still, then you know that you have the pleural lines moving together, so the visceral and parietal pleura, and therefore you do not have a pneumothorax. So those are the things you can look for: absent lung sliding, absent comet tails, and no color Doppler.